Dr. Andre Kushniruk. Dr. Andre Kushniruk is Director and Professor of the School of Health Information Science at the University of Victoria. He has degrees from multiple Canadian universities and conducts research in several areas, including evaluation of the effects of technology, human-computer interaction in healthcare, and other domains, as well as cognitive science. His work is known internationally, and he has published widely in the area of health informatics. His area of expertise includes usability of health information systems, human factors in healthcare, clinical informatics, consumer informatics, decision support systems, healthcare decision-making, cognitive informatics, AI in healthcare, evaluation methods, healthcare system design, data analytics, and visualization. He is a man of vision and has brilliant insights on the future of health informatics. I'll let him take it from here. Ladies and gentlemen, Dr. Andre Kushniruk.
Okay, thanks for the introduction, Henry. So my title today is Health Informatics at the School of Health Information Science, Current Perspectives and Future Opportunities. Before we begin, I want to acknowledge and respect the Lekwungen peoples on whose traditional territory UVic stands, and the Sanghees, Esquimalt, and Wozniak people whose historical relationships with the land continue here in Victoria. So what I'm going to do today is talk about a little bit about the history of the school from an academic curriculum perspective, what we actually do, what we teach, our programs, an overview, where our graduates go, and also a very, very brief presentation of some of our research, just part of it. And on this slide, you see we have two bylines in orange. We have the byline for the school initially that we are revolutionizing healthcare through information technology, and now we've added another one that digital health lives here. So background, as we all know, I think this is a very good time for health informatics. In the past, it was hard to explain. People would say, what is the field? Now everybody knows. Technologies are becoming pervasive everywhere, from the hospital to the home. With the pandemic, the move to virtual care, everyone's heard about telehealth, telemedicine. There are projects across Canada in the area called Hospital at Home. I'll talk a bit about. We also know everyone's heard about there's more data in healthcare, that we need data science and analytics. Healthcare is complex. It's not being done efficiently. And so all of this argued now, as it did in the beginning of the school, that we needed a holistic or integrated view of health and the role of technology in it. So we've been working towards creating a workforce in this for now and into the future. So just a brief overview of the school. Actually, it's been around for quite a while. We are now actually 41 years since it was initiated. And it's had a unique vision about health informatics that I think I'll talk about to some extent mirrors a Canadian perspective, I think emanating from the school. This was a definition of health information science. I don't know where to attribute it to. I think we came up with it. We said it's the field that deals with information processing, including but not exclusively involving computers, and communication in healthcare practice, education, and research. An important aspect about the school is that we're not just focusing on medical immersing, we are looking at how use of health information by healthcare workers, but also by patients and the whole population. Hence why I think we're positioned correctly to say it's health informatics. And this was a slide modified from a textbook by someone who is considered the founder of medical informatics educationally, Ted SHORTLIFFE. And it shows the areas that we draw from. What I did was replace what he had in the middle box in his textbook as medical informatics, and I replaced it and put health informatics in the middle. And we want to argue that health informatics draws from a number of base sciences. You'll see how that integrates into our curriculum, of course, including computer science, but also management science, epidemiology, basic biomedical science, cognitive and decision science. But we also want to argue that health informatics isn't just interdisciplinary, it's become a field in its own right. And I will also show another slide, again, that I borrowed from the text by Ted Shortliffe that focused on medical informatics. I told them I would borrow it and flip it around. In the textbook, he had medical informatics was at the top. I replaced that because health informatics would be a more general concept. And around the top, he mentioned about basic research, so that there would be basic theories and methods that cut across subdivisions. And totally agree with that. So I've labeled that health informatics theories, techniques, and methods. And as you go down, you go from basic research to applied, or the subdivisions of the application of health informatics theories, techniques, and methods. So one of them I've labeled there a subclass. We can consider this a classification or ontology if you want. One of it is obviously clinical informatics. And if we subdivide that, that includes underneath that medical informatics, nursing informatics, dental informatics. So you see, I've modified this somewhat from that text because medical informatics was at the top, and I've added it now as a subclass of clinical. But as new technologies come, we add to the field. I just added bioinformatics as another subclass of health informatics that deals with health information at the level of the genome, the gene. We can add more, it's extensible. We can say consumer informatics is another applied area that deals with information at the consumer level. Imaging informatics is another important area that's arising, etc. And as we all know from COVID-19, there's a lot of talk about developing better programs in the area of public health informatics. We currently have none in Canada, and we're working on that. So you can see this framework goes from health informatics as the most general concept, the applied research areas underneath, and those in turn can be subdivided. It provides a framework for how we consider this in Canada, which is actually quite different from other countries where there seems to be more focus on say medical and nursing informatics in isolation of health, but we put health to the top. Another background slide is that in our school, we've been very cognizant of needing to be able to move back and forth between research, teaching, and practice. We've always thought research informs our classroom teaching and our co-ops, as you will see. Practice in the real world, in turn, informs research and cyclic. So you'll see, hopefully, from what I present, that we've taken this to heart. So, yeah, obviously, we need a more holistic approach to education in this area. And this was recognized, I'll talk about the history back in as far as 1981, when Dennis Probby founded the school. This holistic approach should be part of the real world practice. I've mentioned it should be integrative. I like that term. It integrates from a number of base sciences. And we encourage local, national, and international collaborations with universities, hospitals, governments, companies. And on the few examples I'll give, I won't have a lot of time of our research and consulting, you'll see where this fits. So just a very brief history of the School of Health Information Science. For this purpose, more from the perspective of how we got our current curriculum. So the school, as I mentioned, was founded in 1981 when Dennis Probby was the first professor and director. And he had come in with a background working, he had an IP and math background and ended up working in hospital systems and then came to UVic. And I was fortunate enough to overlap with both of the figures here when I came in 2004 as director. They were both here teaching full-time, they're now both Professor Emeritus. But anyways, back then, there wasn't a lot of curriculum to work from. So the initial curriculum was based on Association of Computing Machinery, had a special interest group on biomedical computing going back to 1979. And Dennis brought some of that in. But another big influence was, at that time, the second person that got recruited was from Germany, Dr. Joachim Moore, who was from a program that freebaded anything in North America. It might have been 1977. I'm not quite sure. But it was, and they had developed a curriculum for health informatics called the Heidelberg-Heilbronn curriculum. So I think between the two of them, the stage was set for developing something that we have since been modifying as we went along. So a bit of a timeline, and we did do an article in the Yearbook of Medical Informatics in 2006 that describes this, although the numbers of students we talk about there is a lot smaller than today, obviously. But 1986 was by the time the first Bachelor of Science, 4-year Bachelor, graduated from this first program. By 1990, there was a grad program established here at the school, we said by special arrangements. So actually the first PhD, I think, was 1994 by special arrangements. In 2003, about a year or two before I came, there was a development of a combined bachelor program, half in health information science, half in computer. The Master of Science became formalized. I arrived, and then in 2005, we developed an online, what we call distributed Master of Science in Health Informatics, became very popular. And then in 2010, and there have been no programs in Canada. We're still the only one in the area of nursing informatics. We created a double master's program with nursing, where a nurse coming in can get a Master's of Science in Health Informatics and a Master's of Nursing. I say 2 for 1, and I'll talk about that in a minute. And finally, although we had people doing PhDs for a while, we formalized that program in 2014. So I'll just say that, yeah, the school has been recognized for education and research. One of the oldest in Canada and North America, devoted exclusively to health informatics. And I'll talk about where the graduates have gone. They're all employed or overemployed, actually. There's very few that weren't able to find really good positions. And currently, we counted up over 1,200 alumni in Canada and internationally. And also the faculty, many are recognized globally and fellows of all kinds of different academies. And some of the faculty have some of the highest citation and publication rates in health informatics, not just in Canada, but globally. So we've come a long way. This is our core teaching faculty. I'll mention a little bit, just a snippet of some of their research at the end, but just to give you an idea of where people came from. Top left was Francis Lau, who was the director before I came, and he had a business background and a PhD in medical informatics from Alberta. Abdul Wasari came later, who had a math and stats type of background that ran a program in London, England in health informatics. Everyone's background was different, as you can see. Elizabeth Bricky had a master's in nursing and a PhD in health services. Alex Ko, we recruited him from Taiwan because he was an expert in database, and Karen Courtney also had a nursing background with health informatics. The bottom row, Helen Monkman, Dylan Crimes, and Simon Menzel, all in some sense were homegrown. They had health informatics degrees. Claudia Lai is one of our newest faculty who had a prior pharmacy background as a pharmacist. And Jesse Gardner, our lab instructor, had both a library science and health informatics background. So you can see we all came from different places. The interesting thing is we now have 11 core full-time faculty dedicated to teaching in the program, free and doing research, 3 professor emeritus, and a lot of adjunct faculty in Sesamo. Some of you may actually, I know, online or in that category. The interesting thing is, although we came from different areas, for example, I previously taught and directed the program in information technology. In general, when we all came here to the school, we moved exclusively to adapting everything to health informatics. And that's very different from other programs in Canada, where the students may take a course from the medical school or take a course from computer science. We've actually all dedicated moving whatever background we had to health informatics. Also, another commonality, all the faculty have real-world experience working in hospitals, healthcare organizations, or companies. The school has really worked to develop close ties with other UVic departments, as you'll see with nursing, computer science, and others. And we also have very strong ties provincially with the UBC medical program and National Nursing, Medical, and Health Informatics Associations. But the nice thing is that we're autonomous, so we work with many different medical programs. We're not underneath one program anywhere. In fact, we're not underneath a medical or computing department at all, which is a real advantage. I have worked in other programs that were either underneath medicine or computer science, and in my mind, that created issues in terms of developing health informatics as a field. So I obviously won't go through this whole list, but as you can see, the adjunct and faculty list is quite extensive. And many of here people on this list are not only from Canada, but US, Europe, international. And we're really lucky to have them involved in presenting in our seminars, doing research with us, and in some cases, teaching some of our courses. So we've been very, very fortunate over the years to develop a very strong national and international network, given that for many years we were constrained by not having enough faculty. So this was really critical to keeping things going. So I will now move into a bit of what is our curriculum. And this is an area that's a moving target, and we've published in it and will continue. We want to prepare graduates for careers in administration, in using technology, education, and in development of health information systems. So right from the beginning, the idea was, how do we get the right mix of skills? A student can't be an expert in everything, but how can we do it so that the knowledge is not too superficial, that it actually, they know enough about database or programming or healthcare to work in that field at a deep level? So the curriculum basically has 3 parts, and we can divide up courses underneath each of these 3 pillars. One obviously is about information technology. Second pillar is about management science for healthcare. And the third one is knowing about health sciences in general. So I'll flip to the next slide. And some of you may be familiar, I don't know if any of you have seen this wheel. It's called the COPES wheel for health informatics curriculum. It's become our national standard. And you'll see that it divides up into 3 parts: health sciences, information science, and management science, with subdivisions of areas that should be covered. And that's no accident, because going back to, I think it was 2005 or 6, in Toronto, a number of us, I was on the COPES board, we had alumni come in, and we had people from other departments in Canada as well come in, and we mapped out what a curriculum would be. So in the large extent, the curriculum I'm showing you mirrored what was from the School of Health Information Science, because as it turns out, a number of us were on that committee developing the national one. And it was a bit funny, because after it was developed, we did an exercise across Canada to see how well that wheel mapped to curriculum of different departments. And of course, it mapped very well to ours, because it had borrowed considerably. And in developing curriculum, we can see for each of those 3 areas, like health science, inside the wheel is, we want to teach about the Canadian health system, so we have a course on that. Clinical and health sciences, there's a course on biomedical fundamentals. On the information technology part of the wheel, we want to teach about information technology, so we have courses on database programming, information management. So you see how this begins to be a framework for developing and adding actual courses into the program. So we've really followed this a lot, and it did, as I said, reflect our curriculum probably around 2005 and 6 when I came to be director in the first time. But the framework also allowed for us to add new areas as they came up. And I put the link for the COAPS website for this one. So we ended up, this was a recent publication in the book called Multidisciplinary and Interdisciplinary in Health. We did a chapter called Towards an Integrated and Holistic Approach to the Discipline of Health Informatics. As you can see, we started with the three-part wheel, and now we've moved into adding a fourth main area we can look at for developing courses, and that is decision and data science. And also working with some of the co-authors on there, Elizabeth Brickey, Helen Monkman, also Karen Courtney, and some others on doing an empirical study of what competencies are needed, and it's coming up to support this type of breakdown as well. So as you can see, we've been developing curricula, publishing it, and the curricula, pieces of it have been adopted internationally, indirectly, like I think a lot of the COAPS one came from our school, and then the COAPS one got adopted, I know, nationally in Australia, some variation of that. So let me now break it down into what the degree programs that are offered by the school, and this is, I think, quite interesting. Well, currently we have the main program at the undergrad level is a 4-year BSc in Health Information Science, and in steady state, I think we have somewhere like about 200 students in it at a time. It's a Bachelor of Science in Health Information Science. I also mentioned we spun off a combined degree with computer science. That's the undergrad programs, 2 of them. At the graduate level, that we've had varying from 80 to 100 grad students at one time. 100 was a little bit too many given our faculty. I think we're around 90. And a number of programs were developed here at the school, including the master's, the joint master's with nursing, PhD program, and we also have one graduate certificate in a specialized area called clinical terminology. And that also is now spun off. We're beginning to do some smaller scale certifications, not full degrees, and we're also doing that as a professional continuing education certificate. So the bachelor's, what is it about? Well, we say it's a program for training in the application of information and communication technologies in healthcare. At the front end of it, we have about 50 new students enter the program each year. Some of them come directly from high school. Others have degrees in other health areas and that maybe wanted better jobs. We'll talk about that. Or others transferring from college. So we have about 50, in some years we've had 60 coming in who first year. In the program, an important aspect of the undergrad program is a co-op program during which students get valuable work experience. In the program, they do 3-4-month work terms and they get paid for it. I'll talk about that separately as well. We don't send them out until they're done about the second year. They have stats, database, a really good background, and then companies in that bid for them. They do 4 months, come back, do some more courses, then do another one, come back 4 more months. So in the end, they do a 4-year degree with 3-year specialized classes, 1-year paid work experience. In the end, they end up in quite high demand. I'll just mention some examples of the undergraduate curriculum. And these are all courses, by the way, that we adapted for health. They're not from the computer department. We developed our own program. For example, health database design. They learn how to create relational databases for healthcare. In the past, our students in the main program would take programming from the computer department, And the combined students still do that, but now we have evolved our own programming for healthcare courses instead, so they can take from our own school where they learn about developing things like programming health apps. Other courses, health information system design was designed specifically around healthcare. When I came here, I brought a curriculum for that course from a computer department and then modified it for healthcare. So you can see we're spinning off specialized courses, healthcare organizations, another course on societal implications, a very important one on legal and cybersecurity. We even have a course on health IP procurement. And last but not least, human aspects of healthcare IP with brought in human factors. And there's other courses as well. Plus, they do courses and stats and other things outside biology and electives. But for the core, we've evolved our own curriculum. So what type of students do well in this field? Some people will ask. I say, well, it attracts people. The main program, it's different with the computer combined, I would say, but the main program, the undergrad, attracts people who like to work with people, very people-oriented, high value on analytical skills and self-motivation. And another interesting point is we actually have, I believe, 60%, at least 50% are women in our program, which is very unusual for a technology program. In computer science programs, it's often less than 10%. So we have a nice balance of people coming in, male and female. And generally, whoever comes in is comfortable at working at the interface of technology and society. It attracts people that are interested in that. Skills, as I mentioned, we want the students to be competent and comfortable working with IP. Speaking and writing skills and communications is so critical and this important part of our program. They do a lot of group work and presentations, but they do also need to understand the Canadian health system, how to analyze requirements, also financial and strategic aspects. Many of our graduates get into upper level management. They need to know how to procure or manage large health budgets. And last but not least, being able to cope with change, because whatever you learn in the program, there's new things coming all the time. And so that's why we're also, I think, moving into more continuing education as well. Other degree programs offered by our school, as I mentioned, we have a combined major with computer science at the undergraduate level, which is essentially half the courses are from us, half of them are from computer science. We have a master's degree. It was a distributed online program. I came here in 2004 and worked a lot with Francis Lau, who had done some very nice groundwork, and using, we were using Blackboard Collaborate, which was an online tool just like Zoom, but this was back early 2000s, and started moving our courses on there for the masters and giving classes, for example, at 5 p.m. PST was the 8 p.m. in the East, and getting people coming in after work. They could come in and do courses, although it didn't work as well when I had a student who was living in Pakistan. That was time zone and other issues. But we were able to successfully launch that. And it was the first online master's program in Canada. Actually, I'm not more familiar with others. There's a few other master's programs in Canada, not a lot. We also have a non-campus stream as well for that. And we also developed a formalized doctorate in health informatics that people could do while they were working. So the online masters, okay, yeah, it was initiated January 2005. And the first cohort, we had students logging in from across Canada and the US using distance and hybrid learning. They held positions already as programmers, analysts, managers. Many were doctors, nurses, working in hospitals and companies. So we began to get different groups of people coming through. And we also had some students that are coming up from our own undergraduate program. So it's an interesting mix of health professionals, IP professionals working in the field, and students that came up from our own degree, which is really, I wouldn't say challenging. I think it's an opportunity for different types of students to work on projects together to see the different perspectives. As I said, people could continue doing the master's while working, although we said it was 2 years, some people took longer, but most people graduated. Here's an example, not even the whole list of our master's courses, but for online and on campus. Of course, we have a class on research methods, data analytics, evaluation of systems, electronic health records has a whole course, health database design at the graduate level, Dr. Cole teaches that. Standards was an area that we brought in a lot with Francis. Project management, we have a course on safety and health informatics by Dr. Baricki, and a number of other courses, not all offered every year, but the core ones are. And the graduate level, there's an option of the student doing a research project or a thesis. If they do a thesis, it's about 2 courses less. It's 7 instead of 9. However, sometimes the thesis can take longer. It's a little bit more substantial than the research project, but very similar. This was an interesting development, and I worked on this one in 2009 with Elizabeth Baricki from the school and the head of nursing, Maureen Frisch and Marjorie McIntyre. And up to that point, and even currently, there was no degree program in the field of the intersection of nursing and health informatics. And we didn't have a lot of resources to start a nursing informatics program. So instead, we created a double degree where a nurse can come in with a certain background, and then if she has enough IP background, or they can do the core courses in nursing masters, the core courses in health informatics, one thesis with 2 supervisors from both, and they actually get 2 degrees. So it's like 2 for 1. They get a master's of nursing and an MSc in health informatics. And after doing this, we realized that we had done something different. In the US, there were a few nursing informatics programs that kind of blended together. This way, graduates come out with 2 different competencies and a stronger for it. So we did publish on that in a couple of articles, including one with our co-op manager at the time about integrating experiential learning into it. They have to do 2 internships. Now, the program, I would say, doesn't have a lot of students, only due to we don't have enough faculty to expand it a lot. But we have, 5 to 10 come in a year, and they really do amazing on the career field because they both have clinical skill and they can also program a relational database. So that's very unusual. The positions they have gotten are amazing, like chief nursing officer, director of clinical informatics, sometimes even before graduating. And last but not least, we have the PhD program. Although we formalized it, I think about 10 years ago, the first graduate in health informatics through special arrangement, I believe, was 1994. So we've had people going through it. It's also, since 10 years, we've made it very flexible that it can be completed while working using hybrid learning and distance. And the focus here is on training leaders that can go into industry. Some have gone into good positions in management and strategy, consulting, and a number of graduates have now also gone on and started new health informatics programs, which we've encouraged. For example, I had 2 PhD graduates, one that started a program in Riyadh, Saudi Arabia, and another one in Iran, and so some of them even went internationally. So another one worked in the program, setting up a program in Ottawa. So what are the current and future opportunities for graduates in health informatics? And I'll just preface this to say, this isn't just the opportunities for people that have the graduate degrees. Many of our undergrads have moved up to some of these positions, in fact, rather rapidly. The chief information officer for the area I live in, Vancouver Island, predated me. She graduated with a bachelor in health informatics, I think around 2000. I worked for several years, and then became the chief information officer for the whole island. Now she's a VP with it. Her name's Kathleen Claver. I don't know if she's online, but we had a number. We had worked out a whole list of who had become directors across Canada. decision support analysts, clinical analysts, project managers, too many project managers being mentioned. They often started in at the analyst level and moved up. Consultants, quite a few working for Deloitte, Accenture. I ended up in New Zealand a few years ago, ran into someone who was in charge of Accenture's health division for the Asia, and she had actually graduated from our bachelor's program about 5 years before. So many, many stories. I won't go into alumni when we're doing marketing. I often end up showing their stories because many of them are quite amazing. Who hire our graduates? These are only a few examples. I'm in BC, so we often have students going to BC Ministry of Health. We've had them going to Ontario Ministry of Health. Regional health authorities, the local ones, Calgary, Alberta, Ontario, now in Quebec as well. Hospitals across Canada, they often work in the clinical informatics groups or head them up. The reason being is that all the hospitals across Canada have and are moving towards electronic records and decision support. In the past, it was difficult for those hospitals to find people with the right competencies. They've often hired graduates from computer science, but maybe they never learn about healthcare. Or they get nurses or physicians, but they wouldn't know what the database, how to program it. So we've kind of, I think, hit that spot in the middle. Many working in hospital groups, but also software companies like Cerner, the chief information officer for that was one of our grads. Companies that make software for healthcare, some have gone to the US. Institutes like the Canadian Institute for Health Information. And the jobs, I would say, are across Canada, the US, the UK, and Australia. An interesting thing about this field, unlike medicine and nursing, is that with this background, you can work in other countries. You don't have to be licensed. If you have an MSc in health informatics, it's pretty exchangeable. So as I said, it's a good area for jobs and careers. Many actually, they come to Victoria and like it and stay on the island. I think I once looked at the stats on undergrad graduates, and many of them chose to stay on Vancouver Island, although they could have gone elsewhere. And as I mentioned, working in hospitals, governments, companies, universities, all over. So going back to COPES, they actually created something called the Career Matrix. And I've just mentioned this one. I think it's quite useful when talking to people about what careers in health informatics. And they have on the side levels from entry level on the bottom, emerging professional, all the way up to expert, and master is in red. And then they divided up columns about different kind of areas within health informatics where careers are, like clinical and health services, where at the bottom they may come in as a clinical informatics coordinator or analyst, often moving up to director of clinical informatics, and then at the master top level, and then up to chief clinical information officer. Again, we can look at any of these rows as columns. There's a column for project management, often coming in at the bottom at project coordinator, moving to analyst. And in many cases, our students skip the bottom and go to the level 2 row. Project analyst is a common one they go in at as entry level. A manager, a director, and then we've had the VPs as well. So what COPES came up with very well match, or at least our experience with where people ended up in industry. And there's even a column, the second from the right, on information management, where people may end up working in the standards area, and at the top there's even chief privacy officer. We've had some people that did the degree and then did further qualification in the area of privacy, and we're trying to add more on that. We may add the micro-credential in that area. So you'll see that this covers a wide gamut when people say, well, what can we do with health informatics? It's a lot. I will mention, I think one of the strengths of our program has been experiential learning. And there's our co-op manager, Jason Bond, and his assistant, Selena. For the undergrad program, I think right from the beginning, it required that students do 3 4-month paid co-ops. And co-ops would be like working, say, with the hospital, There's just one of thousands of examples, interviewing physicians and nurses about information requirements for a portable, and then telling the IP people what to program. So you're kind of at the middle, but there are many examples of it, at the nexus between the IP and the health people. So it's a very important space. Although some people will work more on the technical and some will go more onto the other side. I think this is responsible for why when they do a 4-year bachelor, it's virtually 100% employment, because they're walking in with a full year's work experience, pretty handpicked, because during their studies, they can decide to try to do something in the ministry and say, okay, I don't like that, I want to try something corporate. So at the end of it, they have a pretty good idea of what they like. Oh yeah, on co-ops, they may have positions like becoming framers, training doctors and nurses how to use systems, developers, analysts, testers, helping to gather requirements, writing documentation. So I remember of activities. The example I gave was only one of them. And some of the students, I'd say most stay in Canada. If they stay in Canada, in our program, they probably will all end up getting paid for each month. If they get, some have gone overseas and they've done that because they wanted to, but they're not necessarily paid. Now some statistics. Before the presentation, I asked my assistant Sandy, who is online, to come up with this, how many graduates do we have of the different programs, to give you an idea. And our current stats are there are 1,209 total graduates of some degree from our program in Victoria. Now we can see most of them, 949, graduated from the HINF Bachelor of Science. About 260 have graduated from one of those graduate programs. And we also have some that have graduated with PhDs, I've mentioned about 15 or so, and about 20 with a new certificate we developed. We want to expand the certificates. And the breakdown was 895 with the regular bachelors and 54 with the combined computer. So it's about 1,200 people out there now, which is quite nice. When we have a seminar or something, we can send to the listserv, goes out there. And I don't have it on the slide. Another thing we've done a lot of, because of COVID, is a big push on doing social media. So we now have a lot of social media channels in addition to that. Examples of, okay, so I think I've kind of covered in a nutshell, hopefully it was clear about some of the programs where we got in terms of the curriculum. I will say we are working on expanding. We put in a proposal to the BC Ministry of Advanced Ed to get funding to hire more faculty. I'll talk about that at the end. Although universities are kind of tight right now, but the Ministry of Advanced Ed is understanding that this is an important area. Before I end, I just want to give you a snippet. It's just a snippet. Don't get the idea this is all the research. It's just some of it. And some of the slides I garnered from faculty. We were doing an open house. I said, just give me one slide about a research project you're doing. But as I said, many of the faculty are doing multiple. Well, we all are. But the projects that we do, to give you an idea of the research side, I talked about the two things, are across Canada, internationally. They involve our faculty, many of our students are involved. Many areas, including human factors, patient empowerment, patient safety, system design, mobile apps, and more. So I'll just flip through some of those slides that I got from faculty. Hopefully I give them due explain that. This was a slide I got from Dr. Karen Courtney on telehealth. So she was saying she's interested, one of her areas that she works in is in designing health IP to support like behavioral changes and support existing changes and how we want to change. So she also teaches courses on telehealth and pervasive technologies. So coming in with a clinical background and also health informatics. Dr. Helen Monkman, the slide she sent me was on design thinking, but she works in a number of areas, including design thinking, patient empowerment. There's an example there of a patient journey map, And she also did some very interesting work on e-health literacy. You can see another area of health informatics. Dr. Francis Lau, the slide he had sent me for the workshop was just about one area. It was the science, advancing the science of patient-centered measurement and team-based care in primary health care. So interested in how do we promote team care in primary health, although Francis has had many different careers within health informatics, and standards and terminologies is another one. Dr. Elizabeth Baricki, who many of you know, developed what's called the Global Laboratory for Digital Health Innovation. Her focus in research, although again, there are many other areas she covers, but has been on safety of healthcare IP, and looking at technology safety and risk management, but also looking at this in a number of areas like e-prescribing, electronic medication reconciliation. So there's a whole research program in this, and there's also Michael Smith Scholar in this area where they fund her to work in it. Simon Menzel, one of our teaching assistant professors, very much into visualizations and how can we best display information, for example, about COVID, and how medical imaging can be incorporated into healthcare better. I don't know if Abdul is online. Abdul, the example of research he gave me for that presentation was on telemedicine, how to implement it at multiple levels, from the local to district, regional, and national. And this was from some World Bank work he did actually in Ukraine in 2020. So he also has an interest, I know, in simulations, computer simulations. And Alex Ko, as I mentioned, was a professor we recruited from Taiwan, who is expert on database, and he also is involved in big data and health work and chairs a special interest group on big data for healthcare with IEEE, an engineering organization. And Dr. Dylan Crimes, who's currently looking at predicting success or failure of electronic records in terms of will they be usable for users, and also very interested in big data analysis, machine learning, and using natural language processing and AI in healthcare. And last but not least, everyone other than myself is Claudia Lai, who has a very extensive pharmacy background and worked with Ontario Health and the ministry, and is interested in digital tools for enabling individuals to participate in shared and collaborative decision-making and design of equitable, people-centered learning systems to support being at home. So we're really happy she came on board a couple months ago, and if we're taking 580 or 680, she's there. We're very lucky to have her. I'll just mention one or two I've worked on. This was, I'm working on many projects now. I'm not even sure how many, probably too many, but this was one that I worked on with the other co-PI on it was Elizabeth Baricki, with a digital supercluster project that was funded to bring together industry and university. Very large budget one. We work with companies who bring dermatology diagnosis to point of care. And I'll just say the background on this one I think was interesting was that 1 in 6 Canadians will develop skin cancer. And we analyzed when we put the proposal in from a cost point of view, treating advanced cancer can cost under $200,000, where if it was caught earlier, it might have been trivial cost. But more important than cost, if you know anything about cancer, the longer you wait, the less likely you survive. And catching something early in this space can move your, get you a survival chance of 98%. But if you wait a few months, it can be down to 15%. It'll be untreatable. And this is really bad given that Canada doesn't have enough dermatologists, and the wait time for a dermatologist is around 6 months. So in this project, we integrated AI image analysis and decision support. It was actually developed by a company, and we were focusing on how can we integrate it into the health system. The idea was, it wasn't that the patient at home took a picture, but when the patient went to the GP used the standardized tool, took a picture of the mole, could immediately send it on the cloud, have it analyzed, and it would come back with pictures of how close or not it looked like cancerous, malignant, or cancerous, and then could hit a button and immediately send it to the inbox, all that information to the dermatologist. And what we found in doing evaluation of this was quite interesting. The average time from the GP, general practitioner's office, to the dermatologist before the system was 92 days or 3 months. And think of this, all the time cancer is getting worse. With this system, 84% of the referrals from the GP to the dermatologist were under 5 days, and some of the referrals were in the same day. Like the dermatologist picked it up the same day that the GP sent it electronically, the image and the classification. And when we looked at that, we initially thought, well, that's not even possible, but that was what was happening, is it got sent the same day and it picked up. So just one of a number of areas that I'm working in with some of my colleagues here. Also, many of us are working on usability analysis of systems, not just in the office, but doing remote usability. We can even do remote usability using Zoom. I can log in, get somebody else on another side to work on the system and record what they're doing, having them think aloud. And this came about when COVID came and we couldn't go physically with the camera, but it ended up being even better. We can do usability studies remotely. And a couple of projects that cut across a number of our faculty, as opposed to individual research areas. We were very lucky to get funding about 5 years ago, several million from NSERC, not for funding for the course, but to fund fellowships for grad students. And this is in collaboration with Manitoba. And students that were in our program or math and stats or computer or over in Manitoba, if they took our VADA, Visual Automated Disease Analytics program, well, for one thing, they got a really nice paying fellowship. They had to do 1 or 2 courses on data science that we offered for an internship and each summer workshop. At the time in our curriculum, we didn't have as much data science. This has allowed us to bootstrap and bring in data science as something overlaid on top of the degrees. And as a note, 2 of our current faculty, Bill Crimes and Simon Mitchell, actually went through this program and then bringing back what they learned into, for example, teaching our first years about programming in Python. Yeah. And so far, we've had about 60 plus graduate students. We're in the last 2 years of it, but we'll probably end up with about 100. But we've tried to capture some of what this program covered long-term in our curriculum. So I think, from my perspective, it's been really useful. One other development that cuts across a number of faculty in the school, and if we studied here a few years ago, we wouldn't have seen, we converted, interesting story, a storage room down the hall into a smart home lab where we are testing out different smart home technologies, speech recognition, falls monitors, bed sensors, smart fridge. We got some corporate funding for it to start off with in 2000, and then the Ministry of Advanced Ed gave us a large amount of money to really outfit it and some of the other rooms. So the work on this area is in smart homes. We're using this for teaching. It was being used to teach about object-oriented programming by teaching everything in the room as an object. Hospital at home. We're also involved with Island Health on the project. Telehealth, telemedicine. So you see, this area covers a lot. Sensing devices, ambient assisted living, and the human factors of virtual care. So we're very excited about this. And after Christmas, we're going to have a whole class going in, looking at different technologies that can be added to what we already have. And that was just the specs for how we modified the storage room to make it into a laboratory, and that simulates a house with a bathroom and kitchen. So that's basically all I'm going to cover. I'll just end off with some challenges from my perspective and the schools. one is meeting the demands for graduates. Coates, now Digital Health Canada, did some excellent work on estimating the number of unfilled positions in this space, health informatics in Canada, or digital health, it's synonymous. And I think by 2023-24, it was supposed to be about 10,000. In the US, it's 10 times that. So one of the areas we're interested in is getting more students coming into the program. But because health informatics, for example, isn't known people in high school, we have to do a lot more recruiting and marketing. So because of that, we've been doing a lot of social media and open houses online. And to go along with that, we need more faculty positions and expansion of the programs. That is not to create a large program for no reason with thousands of students, which some programs have, but then there's no demand for the students. In this case, the industry would absorb a lot more than what we could put out, what we could graduate. The other challenge I've identified is the rapidly evolving nature of the field, which is a good part as well. It's enjoyable keeping up with things, or trying to. And this has also led to the need for rapid certification and micro-credentialing, something our new president is saying he really supports. And for example, we have a double degree with nursing, but it takes a few years to complete. We have had contacts from health authorities saying, well, we're putting a bunch of nurses onto an IP project and we need to bootstrap them in less than a year. So we're looking at different types of quicker courses in addition to the degree program. And example of that is our terminology certificate, which is about a year long, but we've also worked with Computing Ed to create a professional version of it. And we have a long list of certificates we want to do, one in virtual health, another one in data science, AI and healthcare, which we'll only be able to do if we get more faculty, so the chicken and egg. And we're also currently expanding, I mentioned our simulation environment, and using that to communicate with hospitals, decision makers, and actually, we haven't done it yet, bringing in people from the ministry to look at what's there. Often the decisions are made without knowing what the technologies are at the highest levels. So we're trying to infiltrate that by getting more grads up the ladder in the ministry. And I would say I didn't have it there. That would be another bullet, is trying to get what we do translated at the policy level, at the governmental levels. We're getting there, but it's hard not to crack. And that's what I have. The bottom picture there is all our staff that support. Some of them are here. I know Sandra's here, and Douglas and Sandy was running the IP on this. And I don't know if the others are there, but yeah, there are supporting crew that support the department. So we're a pretty lean department. We have 11 core faculty and a number of staff, but it runs well so far. And with that, I'll end. I have my email address there if you're interested in more of the information about the curriculum. We're always working on. We're happy to share curriculum ideas anywhere in the world. We do. And if you're more interested just about the school, it's send the his@uvic.ca, and that email could be free or to the right person. So with that, I will end. Exactly 1 hour.